Oh yeah, I'm very happy to be with you here. There was a strike just before the channel, but I could make it. I'm very happy to be with you. So I'm gonna close this session, and I think it's gonna summarize a bit what Michael started with, and then Sejari. So these are my disclosures first. I think from the discussion we had so far, comparing mitral FR, coapt, and some surgical items and features, it's very important to recognize that we are underestimating the impact of the mitral disease. We are under-treating the mitral disease because the patients are under-referred. And even if they meet or they match the guidelines recommendations, they still not referred for surgery, which is still the gold standard so far. So I think one of the most important things we have to work on also is to increase the awareness, together or in parallel to what Michael has been talking about, promoting access to interventional therapies within surgical community. But I think this is also our duty, is how much we believe really in the interventional therapies ourselves. The effort should be done. Some of us did it before, and the success was there, but I think there is no way we avoid that. So mitral interventions have to be looked at with a global approach. So you have what we call the replacements with the big R, and you have the repairs. But the repair, you have what we call the indirect techniques and the direct techniques. So one of the direct techniques we've been showing previously is the mitral clip, and the other one is, for example, the neocord, where you work directly on the components of the mitral valve itself. So the story started a long time ago. Actually, it started 1 year after the first TAVI. So the first TAVI has been done in 2002, the first mitral clip in 2003. But we're still far away from the success that we have with TAVI. And I think it's easy to understand why is that, because the mitral valve itself is very much more complex. And even ourselves, really, we don't know everything and anything about it. We know just the surface of the problem. Recently, the Pascal, it works like a mitral clip, I would say. It's an edge-to-edge technique also repair. Received the CE mark after 59 patient implantation. So it's not that much, but it means also that in parallel to the huge investment of billions for the mitral valve replacement systems, also a lot of money is also invested in the repair systems. However, we talk about TAVI durability. We don't have any really strong and long-term durability data assessing how good are these repair systems. I mean, this is the mitral clip. And for example, if you take coapt, which is the only, we have only 2 randomized controlled trials, mitral FR and coapt. We have only two years follow-up. And in some particular patients, which are really, really highly selected. Yesterday, I was in a meeting with Abbott, and we were looking deeply into the results, and you can know that these guys are meant to success anyway, which is good. But it means that we don't know everything about the problem, and the same with cardioband. So the durability with repair percutaneous systems is to be demonstrated. The other problem is that we look at these interventions without looking at the landscape of the patients who are referred to us. The majority are suffering from degenerative mitral disease. In France, for example, we are not allowed to use mitral clip in functional mitral regurg. It's not reimbursed. It's not allowed. Where the only studies which are supposed to validate the indication in a randomized fashion were done for functional mitral regurg. So it shows you how far we are really from the data that we need to make it really realistic. So Sejari talked about mitral FR, he talked also about coapt. There's nothing to oppose these studies. They are complementary. 2 different subsets of patients, 2 different ways of following up the patients, and 2 different ways of treating even the patients. Even the optimal medical therapy management was different in these 2 studies. So the conclusions are not the same because the patients were not the same. And if you look you do a sub-study in the COAP trial, for example, and you take patients which are similar to mitral FR, the studies are the same. The results are the same. Anyway, if we come back to real-world data, you look at this slide that Joseph Bavaria shared with me very nicely. It showed clearly something very important, that even with the experience, over 3 years of experience, you can see here, we still have at least 30% of patients who are treated by MitraClip who still have echo regurg, which is more than grade 2. And we all know also that if you have a mitral regurg more than 2, it's an independent factor of mortality. If you look at mortality again, look, it didn't really decrease over time despite the increase of the experience that we have and the number of valves we are implanting. So we cannot get satisfaction from this. And it needs also, we have to re-evaluate what's happening differently. And that's why a heart team approach is important. So this is the introduction of what we have so far in our hands, and mostly patients treated with MitraClip. So, I mean, this makes no secret for a lot of you that I believe in mitral replacement interventions. For one simple reason is that I think we have been badly treating for a long time the mitral valve replacement themselves. I'm not talking about patients who are 40 or 45 years old. I'm talking about elderly patients, of course. Because many of the surgeons, you know, like me, I mean, we just cut all the valve. We don't preserve any the submitral apparatus, and if we preserve any, we only preserve the posterior one. We don't look really on preserving the wall apparatus. And if you don't respect that, you fail into you fall into this dark zone where the patients having replacement cannot have and would not have good outcomes later on. I will show you that. So it's very important to preserve the anterior and also the posterior mitral leaflets. There's a lot of physiological studies that have been done to show that. And if you don't do it, that means you're not treating very correctly. And in that case, you cannot compare replacement results to repair results, because with repair, you preserve everything. This is one. The other thing, it's not true. I'm in a center where we do more than 2,000 cases per year. We do more than 350 mitral surgery for repair per year. So we are not big as in Germany, for example, but we are not very small. And we have some surgeons who are dedicated to mitral repair. We cannot repair everything. And if we repair, it doesn't last forever, because we know that some valves are very difficult to repair. We all know this. We just have to admit it. This is a slide taken from Tyrone David publication. It shows clearly that if it's a posterior prolapse, it's easy. It's better than if it's anterior, and it's better than if it's only it's better if it touches the anterior mitral valve leaflet. It makes sense. So this is also a very important slide. It shows clearly that we have better results when we repair, where we have much more results, but all the rest are replacements. And actually replacements are achieved in intermediate, high, and extreme high-risk patients. So this is a bias of conclusion and interpretation. And this is just to show you that if you take out all the submitral apparatus, you transfer a ventricle from a cylinder to a disc, and this is not good for the physiopathology itself. So if you want to do it right, you have to preserve all the apparatus. So this is why I think and I believe that interventions replacing the valve are not so bad, and they need to be well considered in the future, and they are much easier to achieve actually. So we have reached so far more or less 400 implantations worldwide. There are 2 randomized controlled trials running in US, 3 pivotal trials, and Michael said that the first cardiac Q valve was implanted in 2012 in Denmark, Copenhagen, by Sondergaard team. And then so far now we are in 2019, and we have some other valves who appeared, and the last one is completely transcepted. So I'm going to focus on the mostly used valves quickly. This is the Tendyne valve from Abbott. 2 generations, the Tendyne and the Tendyne LP, to reduce the profile of the valve, because one of the problems of these valves is the LVOT obstruction because they are very high in the ventricle, as you can see it here. So they are all self-expandable valves, and they are so far almost all transapical valves. This is the only valve to be repositionable so far and retrievable, and it does not need rapid pacing for implantation. Of course, it needs a lot of work and preparation. It needs a great effort for screening on echo, of course, but also on CT to be sure that we are learning. I mean, we're starting from zero. We don't know if what we're doing today will be doable tomorrow. It takes a lot of time, and even the access, surgical access itself, you need a lot of preparation and meticulous observation. So this is, for example, one of the patients that we implanted. The echo is not running. It's supposed to run. Okay, but anyway, the implantation itself, once you started putting the catheter in the ventricle, it takes 10 to 15 minutes. It's very quick, really very quick. The problem is the access itself. So we have, in a small amount of patients, I admit, 1 year follow-up with this valve that has been published recently by David Muller from Sydney. And it showed clearly that you must not forget that these patients were contraindicated for surgery, were contraindicated for MitraClip also. They had, in the majority of the cases, functional, severe mitral disease and cardiomyopathy. And despite that, you can tell that at 1 year, the results are very acceptable and very honorable, as you can see it here. So it also shows one thing, something very, very important, is that we have been always told, and even the guidelines, we don't consider that if you have a functional mitral regurg, you cannot treat it, because this is a disease which is related to the ventricle itself. But the patient comes to see you. He comes to see you because he has shortness of breath, he's not feeling good, and he is readmitted every week or another to the hospital. He has to go to see a GP and call his family because he's not feeling well. So we are judging the efficacy on only hard criteria, as I would say. But actually the patient needs something else. He needs something better, something more. And if you look just at that, you can see that when you replace, you treat immediately and better, much, much better, the regurg itself. And the translation of this, the success rate is almost 98%. They recover. They do much better. They breathe better, and they even tolerate much better the treatment they have. So this is very important to keep in mind. We should always put the patient first. This is the design of the Summit trial for the Tendyne valve. The other big competitor, I would say, is the Intrepid. So now we have more than 200 patients implanted with the Tendyne, which is the biggest experienced ever. This is the second big, mostly used valve, Intrepid from Medtronic. It also has an internal anatomic disc. I'm sorry, the videos are not running. They were running on the preview room. So it's also a long valve, lower profile, slightly lower profile than the Tendyne. Has different ranges of hooks to attach to the mitral valve, and a large brim at the level of the annulus. It doesn't need that much guides and wires. Actually, when you puncture the apex, you just dilate the hole, and just you put, this is the catheter. It's 32 centimeter catheter, very small, very easy to handle. You go up in the left atrium, you start deploying on echo, you pull back everything at the level of the annulus, you check on echo that you have a good position at the level of the annulus, and then you finalize the deployment. It also needs a good preparation in terms of screening itself. So again, this is one case we did in my center. So it's echo-driven. Michael has been saying that we have to learn wire skills, but also we have as a surgeon to really master all the imaging tools that we have. The CT scan, it makes no sense to give the radiologist the role of screening the patient for you, and also unimaginable just to rely on the echo people, which are very important, but we have to understand what they are saying and also try to behave or react in anything you do. So this is also a very quick and fast implant procedure. It takes hardly 20 minutes from the skin to the skin, I would say. This is the valve opened, the deployment started in the left atrium, and then you pull it back to the level of the annulus, and you finalize the deployment itself. And actually, when the screening is well done, it ends up always with a good result. So, unlike the repair techniques, it achieves almost in all the cases very good results in terms of reduction of the mitral regurg. And the benefit for the patient is also obvious even at 1 year follow-up. So this is also a 1 year survival rate, again, more than 76% of the patients, which is really very good when you have been dealing with patients like this. The Apollo trial is running also, including, it has 2 arms, one randomized controlled trial where the endpoints are much more rigorous than with the quad, and one single arm study, which are running. This valve is also very interesting. It's one of the first that have been used. The Tiara valve, a D-shaped valve, transapical. They are working on transeptal systems. All the valves actually are working on transeptal delivery systems. 32 French, though it's still big to introduce. The caisson that also could be delivered transeptally, but it has 2 decks, as you say. 2 steps of implantation, and the problem is if you have to come back later on and do valve and valve, it's very complex to do it because you have no space actually. You have to go through this, just like the Tundine. The high life, they are starting again a new study in Europe and in Australia and soon in US. So we did a first in man, and I'm very proud to show you this because, I mean, we are a surgical community here, and the first in man with the transeptal Cephea system. This is a valve that has been acquired 1 month ago by Abbott. And they did this transeptal system within a surgical team. But it's a heart team. So if you work really in a heart team and you show consistency with this approach, I mean, you have all the means, I would say, to be there. It's not lost. So the advantage of this valve, and this is the second generation of mitral valve replacement systems, is that it could be done minimally invasively. It spares everything, of course, and because it's very short in the ventricle, I'll show you later, the risk of LVOT is much smaller. And there's an outer disc, protected the internal disc. We think that it could help increasing the durability of the leaflets. We have to wait and see. Only the future will show it. This is the videos from the valve we implanted. I'm sorry that you cannot see it here. So, in conclusion, this is for the Cephea, but I want to quickly finish by this. So there are more and more patients treated with mitral interventions. I think we should all work on creating heart valve centers where we have in common cardiologists and cardiac surgeons, because these competences have to work together. And I think this is one of the last chances for the cardiac surgery community, really to play a major role, not only a passive one, but an active and proactive one. Because at this stage, it's like the early years of TAVI, we need to work together. But if we don't really show a will to do it together and adopt these kind of techniques, I think it will be very, very late for us to keep on encouraging other and young generations to come and join us to do this wonderful specialty that we have, because it's very time consuming. It's much more demanding. The learning curve is much longer than learning to do a TAVI or mitral. We all know this, and it needs a lot of sacrifices. But I mean, we have to do this effort, otherwise we will not be attractive anymore. Thank you very much.